is painful leg syndrome. Now, as you see, the topic actually is very vague. What do we mean by painful leg syndrome? It means different to different physicians. So what I have done during this lecture over next 22 minutes, I am first going to show you three cases. We'll ask you questions which is common to all the three cases. Then I will build up my lecture, and in the end, we'll come back again to these three cases. So case 1, 63-year-old man, 3-year history of type 2 diabetes, receiving metformin 500 milligram twice a day. Patient has no evidence of retinopathy or nephropathy. HbA1c is 6.5. Patient complains of recent onset of pain in buttock, which moved to the other side, also associated with weakness of leg and difficulty in climbing from chairs. If we see, proprioception is slightly reduced from toe to ankle. He has a strength of 1:5 proximally, while the distal strength is almost normal, 4:5, and there is no evidence of entrapment. Ankle and knee reflex are absent, rest are intact, and if you see 10 gram monofilament with sensation is preserved. Second case, again, a 65-year-old lady, 10-year history of diabetes now. In contrast to previous case, where there is 3 year, a 10-year history of diabetes, not controlled, HbA1c of 9.5%. Patient has retinopathy, nephropathy, receiving metformin, glimepiride. She complained of recent onset of burning, tingling, stabbing pain in the feet that get worse at night, interferes with sleep and activity of daily living. She is anxious and depressed. She presented with decreased sensation to pinprick up to knees, decreased vibration sensation, and loss of 10 gram monofilament. She has a strength of 5/5 proximally and 4/5 distally. Ankle reflex is absent, and she has no foot ulcer, amputations. Pulses are palpable, and there are no deformity or callus. Third case, 65-year-old female type 2 diabetes, again long-standing. Patient is receiving glargine, metformin. Patient has hypertension and dyslipidemia. She has insufficient sleep, common nocturnal awakenings from last 10 years, chronic burning sensation in lower limb that get relieved by movement and household work. Neurological examination, no focal abnormal signs. HbA1c 8.4, which means diabetes is not controlled. Thyroid function test normal, no vitamin deficiency, EMG normal, NCV normal, and patient has been prescribed duloxetine by a physician for presumed diabetic neuropathy. So I have told you three cases, three presentation of painful leg syndrome. So the question to all who are attending this course is all the three patients suffering from diabetic polyneuropathy? If answer is yes, then obviously there is no workup needed. If answer is no, how would you work up these patients further? And then if the diagnosis is different, how will you manage these patients? So these are three important questions. Since this is a webinar, I request you to write down your own options with you, and we will come back to these cases again. Coming back to neuropathy, it is one of the most common and troublesome complication of diabetes. And almost 60 to 70% of neuropathies which are observed in diabetes are associated with pain. Why it is important to understand about neuropathy? Because neuropathy increases the risk of amputation by 1.7-fold. If it is associated with deformity, the risk of amputation increases by 12-folds. And if there is a past history of ulceration, the risk of amputation is increased by 36-folds. How to define diabetic neuropathy? It's a diagnosis of exclusion. Remember, diabetic patients are not immune to non-diabetic problems. So diabetic neuropathy in a patient of diabetes is a diagnosis of exclusion. We have to rule out that patient is not suffering from some other causes of neuropathy. Risk factors, we will not spend much of that time. In diabetes, obviously, poor control of glucose, duration of diabetes. The longer is the duration of diabetes, more poor is the control, more are the chances to develop microvascular complication, apart from numerous factors which has been listed down here. Now, when we see a patient of neuropathy, first we have to classify whether patient is suffering from acute painful diabetic neuropathy or chronic painful diabetic neuropathy. Now, in acute painful neuropathy, the duration of diabetes is short, that is usually less than 3 years. While in chronic painful neuropathy, it's a long duration of diabetes, which means acute painful neuropathy, there might not be associated other microvascular complications. Onset is usually acute. In chronic painful, it is gradual. Pain duration, again, is a short duration of pain in acute painful, while in chronic painful neuropathy, the duration is long. And if we see etiology, it is usually metabolic factors which are responsible for this acute painful neuropathy, in contrast to structural damage to peripheral nerves in chronic painful neuropathy. Usually, acute is self-limiting, relapses are rare. In contrast, chronic persists for a year, relapses are frequent and very difficult to treat for physicians. What is the mechanism of pain? Initially, it's a peripheral tissue injury, because of which there is a release of arachidonic acid, there is activation of nociceptive receptors, release of substance P, and patient perceive acute pain. But when it persists, the prolonged intense pain, there is a message to central nervous system where there is an activation of NMDA receptor, central sensitization, and neural and glial remodeling, which will result in long-term potentiation and chronic pain. Which means when we see a patient of painful leg syndrome in a diabetic patient, we have to first classify acute versus chronic. And then if we see an acute, we have to prevent a transition from acute to chronic pain, and we have to act at multiple levels. How to treat? Now, obviously, good glycemic control is of utmost importance for all microvascular complication, irrespective of duration of diabetes. Good glycemic control is of utmost important. Control of blood pressure, lipids, cessation of alcohol, and smoking. There are a number of drugs which are needed for control of pain, which we will discuss. Now, as far as control of diabetes is concerned, again, I will not spend much of the time. As I have told you, DCCT, UKPDS, every trial has shown that if you will bring your HbA1c to less than 7%, you can prevent progression of microvascular complications. Now, there are many therapies for painful neuropathies, which are listed here, including antidepressants, which are tricyclic antidepressant, antagonist, opiates, and atypical opiate analgesics. Seeing lots of drug, the next question which comes to the mind, how to choose them in a given patient? What are the logical first line alternatives? So for that, I have made this table to show you that there are first tier agents, second tier agents, topical agents, and others. What are the first tier agents? First tier agents are those drugs with whom we have more than 2 randomized controlled trials in diabetic polyneuropathy. And there are only 3 drugs: duloxetine, pregabalin, tricyclic antidepressant. Second tier agents are drugs where we have at least one RCT in diabetic polyneuropathy and other RCT in other painful neuropathy. And then we have carbamazepine, gabapentin, lamotrigine, tramadol, venlafaxine, and so on. Topical agents which act on substance P include capsaicin and lidocaine. Others include drugs where we do not have RCTs in diabetic polyneuropathy, which means they has been tested in other painful neuropathy. And we have citalopram, we have paroxetine, we have phenytoin, topiramate, and bupropion. So that's how these drugs can be classified based on evidence which has been generated with them in diabetic polyneuropathy or other painful neuropathy. So how to choose a drug in a painful neuropathy? We can choose based on pain descriptors. If a patient is giving history of dysesthesia, which means painful sensation when something is touches that otherwise would not hurt. Patient has burning sensation, sunburn-like sensation, or skin tingling. In these type of cases, capsaicin, pregabalin, gabapentin are preferred. If patient gave histories of paresthesias, which means pins and needle, electric-like sensation, numb but achy, feeling feet like in ice water, knife-like, shooting pain, lancinating pains. In these cases, tricyclic antidepressant like amitriptyline, carbamazepine, phenytoin, mexiletine, and tramadol. And third group of pain include muscular pains, dull ache pains, night cramps, band-like sensations, or drawing sensations spasm, deep aches, toothache-like sensation. In all such cases, NSAIDs and muscle relaxant. And if we are not able, patient has combination, we may even need to give combination of these therapies. The next important issue is that diabetic patient, as has been discussed in these three cases, they are usually elderly, having number of comorbid conditions. So how to choose a drug? If we think about medical comorbidities, if in presence of glaucoma, orthostatic hypotension, which is quite common in diabetic patient who have long-standing diabetes, patient who have cardiac abnormalities, again a common issue in diabetic patient, hypertension, you can use any first-tier agent but avoid tricyclic antidepressant. If patient has a renal insufficiency, then you can use any first-tier agent, but then you have to change the dosage of pregabalin with creatinine clearance less than 60, and duloxetine is not recommended with creatinine clearance less than 30. And I have written these things with purpose because we have seen prescriptions where these drugs are written irrespective of their EGFR. If patient has hepatic insufficiency, then out of the first-tier agent, duloxetine is to be avoided. If patient has issues with fall or balance issue, then please do not use pregabalin or tricyclic depressant. You are only left with duloxetine. So this is how we have to choose out of these three first-tier agents depending on various medical comorbidities. If patient has psychiatric comorbidities like depression, anxiety, which are quite common in diabetic patient, in presence of depression, you should choose duloxetine or TCA. Avoid pregabalin. If patient has anxiety, then any first-tier agent can be used. If patient has somatic issues like sleep disturbance, then use any first-tier agent. Erectile dysfunction, which is quite common in diabetic patient, all first-tier agents are not to be used. And I do not know, I have seen lots of patients where they have erectile dysfunction and they are given pregabalin or they are given TCA. Here the drug of choice is venlafaxine. If cost is a concern, then everything is forgotten. We are only left with a cheaper generic drugs like TCA. For drug-to-drug interaction, which are minimum with pregabalin, large number of drug interaction are seen with duloxetine and TCA. Weight gain and edema are important issues. And for these, pregabalin has to be avoided. Moving further, if patient is not responding with one drug, we can use combination of drug. For example, if you have prescribed duloxetine and patient is not responding, then please do not add another drug from SNRI class or TCA or tramadol. For these patients, pregabalin or opioids can be used as an add-on drugs. So that's how rationally we should choose therapy in our patients who are having diabetic painful neuropathy. These are dosage of various commonly used drugs, which I have tried to list here, like tricycline, which is amitriptyline from 25 to 150 milligram, for pregabalin 150 to 600 milligrams. Moving forward, so how to use these drugs if you have a patient where you have confirmed diabetic painful neuropathic, then you can use out of tricyclic antidepressant, serotonin norepinephrine reuptake inhibitor, which is duloxetine, and voltage-gated calcium channel alpha-2 delta ligand, which is pregabalin. Out of these three drugs, I have told you how to choose one of them. If there is no effect, try another first line, or if there is a partial effect, try combination of drugs. If all the three classes and combination therapy fails, then we can take help of opioids and tramadol. So this should be the sequence of drugs which we should use in a patient of painful diabetic peripheral neuropathy. Moving on to another important problem in diabetic patient is restless leg syndrome in diabetes. It's a neurological movement disorder. Patient has uncomfortable sensation in limb, which are subjective and difficult to describe. Symptoms are usually eased by movement, and studies have shown 7 to 10% of adult population meets diagnostic criteria of resting leg syndrome. We will come to that. It is more common in type 1, type 2 diabetes, as well as in women with history of GDM. What are the common descriptors for restless leg syndrome? Sensation of pulling, creepy, aching, burning, crawling, tingling, painful, and cramping. So various types of pain descriptors are used. And when Henning is given an acronym, urge. Urge stands for, U stands for urge to move leg, usually associated with unpleasant leg sensation. R, rest actually induces the symptoms. G, getting active physically and mentally brings about relief. E, evening and night makes symptom worse. So remember the acronym urge. Try to fit into your patient. If patient is fitting into it, patient has restless leg syndrome. There are a number of drugs which we commonly used in patients of diabetes, which actually exacerbate restless leg syndrome, like metoclopramide. We use it in combination with uh, for so many gastroparesis and other disorders. We use antidepressants, like we have discussed for diabetic painful neuropathy, which can again exacerbate restless leg syndrome. We use anticonvulsants, which can again exacerbate restless leg syndrome. So remember, number of drugs which we give in diabetic patient are actually exacerbating restless leg syndrome. It is common among patients with type 2 as well as type 1 diabetes. And as you see clearly in this cross-sectional study, it results in poor sleep quality and overall poor quality of life in diabetic patients. How to make a diagnosis? There are essential diagnostic criteria, supportive clinical feature, and associated features. These are diagnostic criteria given by International RLS Study Group. There are 5 essential criteria. What are these? If you remember that acronym which I have given to you, urge, a strong urge to move legs. Symptom begin or get worse during interval of rest or inactivity. Symptoms are partially or totally relieved by movement, such as walking or stretching, and worsening of symptoms during evening or at night. Existence of all these 4 features are not due to other medical or behavioral conditions like myalgia, venous stasis, leg edema, arthritis, leg cramps, positional discomfort. So these are common descriptors which we have to rule out. So that's how it is very easy to make diagnosis of restless leg syndrome. How to treat? If they are intermittent, then we give medications like levodopa, benzodiazepines. If it is a chronic and persistent, then non-ergot dopamine agonists like pramipixole, ropinirole are drug of choice. And if patient is not relieved, we can take help of alpha-2 delta calcium channel ligand, which are gabapentin, pregabalin. So clinical feature which will help us in choosing the therapy in patients of restless leg syndrome. If patient has very severe restless leg syndrome, comorbid depression, obesity, or metabolic syndrome, then dopamine agonist. If patient has comorbid pain, comorbid anxiety, or previous other addictions, then alpha-2 delta ligand. If patient is not responding to one line of agent, again, as we have discussed, we can choose combination of therapy. At the same time, try to find out reasons for refraction. And one of the common reason is iron deficiency, which can be because of underlying CKD or otherwise in such type of patients. These are commonly used therapies for restless leg syndrome and their dosage. Because of time shortage, I will not discuss them in detail, but remember, restless leg syndrome does not have a constant effect during 24 hours. Most of the time, as we have discussed, the symptoms comes late in the evening or night. So we should use drugs which have a short, these drugs have a short half-life. So they should be administered at few hours before symptoms are beginning in the evening. What are the effectiveness of pramipixole therapy in type 2 diabetes with restless syndrome? This study has shown that with use of pramipixole, symptoms of restless leg syndrome as well as quality of life improves significantly. And when these things are improving, even glycemic control improves in these patients by an HbA1c of to the tune of 0.3%. Coming back to the cases, this is case number 1. Now, if we see this case does not have diabetic neuropathy. And why I am saying so? Because diabetic sensory polyneuropathy is related to duration of diabetes and degree of hyperglycemia. In this patient, only 3-year history of diabetes. There is no history of retinopathy. There is no history of nephropathy. And patient has pure motor proximal weakness diabetic sensory polyneuropathy is not pure motor syndrome, and it is not associated without other features like retinopathy and neuropathy. So how to do this workup? We should ask for NCV in this patient, which shows a decreased motor conduction. CSF fluid protein is increased, and this patient is suffering from proximal chronic inflammatory demyelinating polyneuropathy, for which treatment is intravenous immunoglobulin with or without high dose prednisolone, and if not response, followed by azathioprine or etanercept. So there is no role of drugs for peripheral neuropathy, which we have discussed. Coming to case 2. Now just have a brief look at case again. Now this is a typical case of large and small fiber neuropathy, which is consistent with diagnosis of diabetic sensorimotor neuropathy. Now, in all such cases, apart from control of glucose, we should pay attention to thyroid function test. We should pay attention even to vitamin B12 levels. If vitamin B, because it has been shown that long-term use of metformin is associated with vitamin B12 deficiency. Apart from that, in this patient, we have 3 drugs, pregabalin, TCA, SNRI. How to choose? Now, depending on comorbidities, as we have discussed, because patient has sleep disturbance. So what we choose, pregabalin or TCA. Now with pregabalin, there is issue of weight gain, fluid retention, glycemic control. So one may go for TCA in this patient, and if TCA is not to be given because of glaucoma, because of orthostatic hypertension, because of cardiac condition, then we are not left with anything but with pregabalin. Lastly, in this case, always prescriptions, we have seen prescriptions where vitamin B12 in various permutation and combinations are written. There is no documented role of vitamin B12 until and unless there is a documented deficiency of it. So if your vitamin B12 levels are more than 350 picogram per ml, then probably we do not have data to show that addition of this drug is going to benefit this patient. And then lastly, alpha lipoic acid. Again, it is coming in combination with various vitamin B12 and other drugs. Always remember, in Sydney trial and in Aladdin trial, it has been shown that alpha lipoic acid is effective when it is given in a dose of 300 milligram twice a day. Unfortunately, most of the preparations which are coming to the market, they contain only alpha lipoic acid in a dose of 100 milligram a day, which means they are not going to be helpful. Coming to the case number 3. Now, in case 3, we have diagnostic criteria fulfilled for restless leg syndrome. So for this patient, we started pramipexole 0.7 milligram a day at bedtime along with iron supplementation. At follow-up 3 weeks later, patient's sleep habits were significantly improved with improvement in discomfort. To conclude with, painful leg syndrome is highly prevalent in diabetic patient. It's a disabling condition. It is associated with considerable healthcare cost. Current management for diabetes revolves around good control of pain and giving symptomatic treatment of pain depending on the underlying etiology. We have to differentiate, as I have discussed in this lecture. Therapeutic options targeting root cause, that is underlying pathophysiology, have not been sufficiently utilized. Thank you very much.